3, 2, 1. We are live now.
Okay.
Sir, Chatterjee sir, kindly stop your slide sharing, sir.
Okay.
Chatterjee sir, kindly stop your slide sharing.
Slide sharing stops now.
Okay. Good morning, everyone, to the second episode of Jharkhand Orthopedic Association PG teaching webinar. We have our speaker as Dr. Professor Aloo Agrawal sir from AIIMS Raipur, Professor David Chatterjee sir from Bardhaman Medical College, Professor Dr. Harpal Singh Selhi from DMC Ludhiana, and Dr. Chadda sir, the Vice President of Indian Orthopedic Association. And to welcome all these speakers, I would like to invite the President of our Jharkhand Orthopedic Association, Dr. Mukesh Prasad sir, to kindly invite all the speakers and participants of this webinar. Over to you, sir. Mukesh sir, kindly unmute yourself, sir. We are not.
Okay, thank you, Dr. Manish. I welcome all the faculties in this PG webinar program, and the faculties, namely Dr. Aloo Agrawal, Dr. David Chatterjee, Dr. Harpal Singh, Dr. Chadda sir, Vice President IOA. So it's a very good initiative, and I'm very happy for the initiatives taken and the great role being played by Dr. Manish. So let us begin this program in the interest of our young orthopods. Thank you very much.
Thank you, sir. Now I would like to invite the Secretary of Jharkhand Orthopedic Association, very young and energetic, Dr. Nepal Kumar, to give his opening statement. Over to you, sir.
Thank you so much, Dr. Manish. Johar, that's a sweet way of welcoming everyone on behalf of Jharkhand Orthopedic Association to all our esteemed faculties today. At the same time, I would like to welcome and thank at the same time all the people watching this program today. And since this is our second episode, and considering the responses we got for the first webinar, I'm sure that this is going to be a bigger hit, and it's going to really benefit the people who we intend and target to. So with that short note, I would again welcome you all and wish you all the best for the program. Thank you.
Thank you, Dr. Nirmal. We have 4 scientific sessions in this program. Each scientific session consists of 30 minutes. We have 4 different moderators for the scientific session. Dr. Saubhik from RIMS Ranchi, Dr. Birendra Kumar from Bokaro General Hospital, Bokaro, Dr. Rajesh Thakur sir from TMH Jamshedpur, and myself from AIIMS Devgarh. So starting the program, there is some slight rescheduling. The first speaker will be Dr. Aloo Agrawal sir, and for this I would like to invite Dr. Rajesh Thakur sir as a moderating this session. Over to you, Rajesh Thakur sir.
Thank you, sir. Thank you. And good morning, everybody. I see this moment as a great opportunity to introduce stalwart Dr. Professor Aloo Chandra Agrawal. While talking about him, you can go on and on and on. So I beg your pardon, sir, Aloo sir, if I go short. After MBBS, he has done MS, DNB, and PhD in orthopedics and FAMS. At present, he is President Indian Stem Cell Study Group India and President-elect Chhattisgarh Orthopedic Association. At AIIMS Raipur, he is HOD Orthopedics. He is Dean Academics, Chairman Medical Education Unit, and Chairman and Nodal Officer Organ Donation and Tissue Transplant. He is Editor of Central Zone of Indian Orthopedic Association, Associate Editor at Hand Section IGO, Ex-Associate Editor IGO Elect, Guest Editor Journal of Orthopedic Diseases and Traumatology BOA, and Journal of Orthopedics Traumatology and Rehab since 2009 till 21. He is a member of... Am I audible, sir?
Yes. Rajesh,
Okay, fine.
sir, you are audible.
Okay. Is member of Orthobiologics Committee, Indian Orthopedic Association, NMC Licensing Committee, IOA, ex-member Editorial Board, IGO elected. He is chairman, IMA Academics of Medical Sciences in Raipur branch, honorary professor, IMA. He has a very vast works experience. I should go one by one, as he was assistant professor, NSCB Medical College, Jabalpur from 97 to 2003. Then till 2011, he was assistant professor there, and till 2013, he was professor. And at present, is professor at AIMS Raipur from 13 till date. As far as his recognitions, awards, prizes, fellowship are concerned, he has got IOS UK fellowship in 2008. In 2, he got J&J fellowship, and in 1994 from KMCH Coimbatore, he got a Kovai Hinduja fellowship. In 2005 from NAMS Sir Sri Ram fellowship. In 2008 WSS Record fellowship. 2001 MP BOS LTMC fellowship. 2012 MP Odisha fellowship, and 14 CG Odisha fellowship. He has authored a book, Structuring a Need-Based Curriculum for Medical Undergraduates in Orthopedics, published by Rani Durgavati University, aided from UGC. And under his belt, he has few chapters like Stress and Pathological Fracture, Neck of Femur, Management Guidelines, Role of HRT in Prevention of Treatment of Osteoporosis, and Monogram HRT in Menopause and Andropause. Many more are there, like lateral condyle fracture in FAQs and practical examination, biomechanics of joint, osteoarthritis, etiopathogenesis management in textbook of ortho rheumatology. In textbook of ortho and rheumatology, he has many more chapters. As far as academic achievement is concerned, he has got university gold medal in anatomy, pharmacology, and surgery, respectively in 86, 87, 89, and 2 college silver medals, second rank in first MBBS and final MBBS, and 3 certificate of merits in FMT, ENT, and surgery, and international best paper award in 5th Kobe International Conference in Coimbatore in 94, and national best paper award in 2004. He has many more awards like MP State Best Paper Award, International Best Paper Award in 2006, 2010, President Appreciation Award, and many more in coming years. In 2017, he got IOA Special Appreciation Award also. And as orations, he has like ML Rathi orations in 22, in 13 as Dr. S.C. Goel oration, 2014 as Dr. B. Das oration, 2013 as Dr. O.P. Sarma oration, and in 22 as Dr. Mahurkar orations. He has total around 200, above 200 publications in Google Scholar and 130 in ResearchGate, and citations 131 and reads 7075. So if you ask me, I can go on, but I will not take much of his time, and I will request him to go for his presentation for our PG students. Thank you, sir.
Thank you, Dr. Rajesh, for such a detailed description. The topic today given to me is how to approach theory examinations. And this is a very important topic. So for all the postgraduates watching this, I have to tell them that the preparations for the theory examination starts right from the day you join the course. You have decided orthopedics, it is your hobby. You have to love your subject. You have to daily say, I love my work, I love my duties, I love my job, and to prepare for it. Remember, no one can read all the theory in a few days. No one can revise all the theory in a day, and no one can treat, discuss, diagnose properly without knowing the subject. And so it is important for you that right from the starting you know what is your syllabus, what is the theory pattern of your university, and what are the books that you have to take. These are the recommended textbooks for you. When you look at the list, the whole desire to read goes off. But then, if you look carefully into it, there is a small book on tuberculosis of the musculoskeletal system by Dr. Tuli. So it is the book you read in 2-3 days and lifelong you know the whole subject. There's a book right on the top, Apply System of Orthopedics and Fracture. And you can just read it as a storybook. Same is with Watson Jones. Turex Orthopedics and Mercer's give you the basics. While in all these 3 years, whatever you do, the procedure that you are assisting, if you just open your Campbell and read it from there, at the end of 3 years, the whole book will be have been revised. Sometimes for pediatric orthopedics, you go for Tactigen. For putting plasters, you go to John Shanley's close treatment. For putting tractions, you go for Stewart's textbook. And to learn how to examine a patient, you go to S. Das. And these are basic books. We also recommend Pi's Surgical Handicraft to the people because that tells you how to go for painting draping, how to tie a bandage, how to put knots, what is the purpose of xylocaine and other drugs. So basic book. And if you love your subject, all this comes not like a teaching. It just comes and gets imbibed into you. These are the good journals that are there. Indian Journal of Orthopedics, JBJ's both British and American, OC and Orthopedic Links of North America, Clinical Orthopedic and Related Research, Yearbooks of Orthopedics. While you can also read the Journal of Rehabilitation from Mumbai and Journal of Rheumatology and Physical Medicine. It is a good habit to go through the journals once a while, and your college will also be having journal reviews. So you will learn that when you read an article, what is the type of study, what are the lacunas into it, how to do the marking, and then yourself how to do research and go ahead. So the next point was know your syllabus. This is again very important. If you look at this list, it looks, oh, what is this? Basic sciences, infection having osteomyelitis and septic arthritis, metabolic bone diseases, oncology, bone tumors, inflammatory arthritis, ankylosing spondylitis, rheumatoid arthritis, joint replacements, ligament injuries, congenital disorders, traumatology, all fractures, spine, hand, foot and ankle, rehabilitation, doing research and statistics, epidemiology, ethics, medical legal aspects relevant to the discipline, and health policy issues. But then you can just make it simple. And once a case comes to us, we think in these lines. Is it congenital, traumatic, inflammatory, or infective, or neoplastic? Is it metabolic, degenerative, or idiopathic? And the whole syllabus related to the bones comes into these small 6-7 illnesses. In every case, while taking the history, you have to think in the same lines. One thing is very important that you should know your theory pattern, because that is how you will practice how to write. Now, some universities like AIMS Rishikesh, they give theory 4 papers, all MCQs. Some people combine brief question pattern questions, short questions, and long questions in the theory paper. DNB people give 10 questions of 10 marks each per paper. Our university gives 2 long questions and 6 short questions. Some people give 1 long question and 6 short questions with a paper of 80 marks. Some people give it of 100 marks. Usually people give 4 long questions and 1 short notes having 4 or 5 into them. Long back, a university in Maharashtra used to give only 1 long question. So you have joined the course, your college is running from a long time. You should know your theory pattern. So this will be my question pattern. And that will be easy by seeing the question papers of the last year. For the first year, people will know that they have to work in the ward. They are residents. So they have to stay in the ward. And at that time, they can read basic anatomy, how to go for clinical examination, learn about traction, putting plasters, have a handbook of trauma, and of course, Pi's surgical handicraft. But then later on, they can work in the ward. They can assist cases in the OT and also read surgical exposures by Hoppenfield. Each case to be read by Campbell, and then going for the surgical steps as described both before and after assessing the cases. So what will be the ideal reading? You have to read about what you do, what you assist, what you prepare, what you operate, and then daily write down it in your logbook, and that too with diagrams. So once you write it down and put the diagram, the whole subject is open in of you, and you will never forget it. And the 3 years will pass off, and your theory paper will also pass off without any difficulty. I feel we should not come to this figure that I shouldn't have waited until the last day to study. Because the subject you have taken on the choice. So it is not work for you, it is play. You read it, you do it, and you yourself will feel okay, how interesting it is to read orthopedics. Coming to the second part, tips to success. Let us go for the study skill overview. So first thing becomes attend all the classes. It is very important that you attend all the theory and practical classes conducted by your department. And why? Well, in the practical examination, you need to perform clinical examination in front of the examiner that you will learn in the class during the entire training period. And in theory, you are taught in such a way that the subject looks easy. So even difficult things, once you hear from your teacher with his demonstration, his voice, his chalk and talk on the board, the subject becomes very easy. Second thing becomes that you go for the concept behind the specific case. You should be able to read the question in your practical book carefully and thoroughly. This will help you in understanding the principle that works behind the particular case. If you are knowing the concepts, it will be easy for you to recall the things while writing down the theory paper. Remember, if you read, you may remember only 50%. But if you hear and read, it comes to 60 to 70%. And once you practice it, do the thing, and then try to write, you may be coming up to 100%. So again, what is more important? Pay attention to the theory classes. Remember, all practical experiments are an extension of the theory. Hence, you must study and be prepared to apply the theoretical knowledge that you acquired during the course of the study. The department should have an environment where the residents can approach the HOD, the teachers, the faculty, the senior residents for any difficulties they face during their work, during their learning, during their understanding. You should be able to inform your teachers and demonstrators if there are any doubt or face any kind of learning difficulties. You should also inform them that what support do you need. Not all can purchase all the books, but they will be in the departmental library, they will be in the college library, and each of you must be having many books in your mobiles and laptops, so they can be shared. So that is the additional support. And your department will definitely consider your demands and provide effective solutions and facilities as and when required. Making notes is a very good habit. Make sure that you learn precautions that every student needs to undertake while examining a case. You should be able to write them in the form of notes in a notebook. And most often, the examiner will be asking these things only. Again, I want to emphasize, know the paper pattern. If you are aware of the pattern of the paper of the subject, it will become easier for you to study and examine the cases. You can divide the time in a ratio of number of questions and marks, and then only start reading them. And you should be able to practice to write and draw before exams. Writing and drawing cleanly is very important. I will tell you later on. When you are working in the wards and the OT, learn the procedure. While you are learning, make a series of steps in the way the demonstrator approached and examine the cases. Different examinations follow different procedures. And once the eyes know what to see, when the mind knows what to do, the brain also knows what to write. There will be diagrams and charts in the books. Please follow them carefully. Read what is written below it. Always try to visualize and draw rough diagrams, and they should be neat and clean. While writing the examinations, you need to learn and remember the diagrams. After learning and writing the concepts, practice the concepts. Once you practice them, they are in your heart and you can write them multiple times. Before the exams, do them at least twice and also practice correct techniques under guidance. You have to think smart and measure accurately. Exams are all about being sharp and quick in performing actions. Thinking smart involves doing the right things at the right time and being aware of all the rights and wrong actions. That is what will be coming in the papers also. Indications, contraindications, procedure. You can sharpen your senses by trying to identify each thing in the word from a distance and speak 5 sentences on it. So pick up a bandage and you should be able to say, this is a roller cotton bandage. It is having starch. It has got a body. It has got a tail. You have to deroll it. So try to speak any 5 sentences about each and everything. This is an intracap. Try to speak. So once you try to speak those 5 sentences, you will be definitely able to write anything in the question papers. That will sharpen your senses. As a student, you need to be confident. Whatever the examiner asks you to write in the exam. During the exam, all you need to do is to remain calm and write the examination well, so that your answers are self-explanatory during the examination. The moment you enter, you start writing, and wherever you read the question paper, read the paper, relax and concentrate during the examination. You might get a topic that you have prepared to write. So prepare well from the theory books and you have practiced. So all the questions will be the same that you have already practiced. Don't take tension. Do not get tense during the examination. And never forget to read the instructions and ensure to perform as requested by the examiner. You should be able to explain the minute steps associated with the examination and let the examiner know if you do not know any answer instead of answering wrong. You have to read the questions and choose wisely. Most often the students pounce on the first question and they start to answer. You need to read the paper carefully and plan accordingly. Discover whether any other question is easier than the one you choose. Plan your answer first and then start answering. Try not to spend 2/3 of the time answering a single question, which you could easily complete in 1/3 of the time. This is a very important thing. Try to visualize what you read. You should not simply read the question and their answers. Reading is the first step of understanding the theory subjects. To ensure that we understand what we are reading, we should take a pause and visualize it in our head. How is it going to help? Suppose I am going for the posterior approach to the hip joint. So from where to where will be my incision? Posterior square spine, collective for the trochanter coming down. What will be the structures? So you try to visualize it. It will be the skin, subcutaneous tissue, deep fascia. You will reach the bone. You will split the gluteus maximus. So if you will visualize, then how will you forget it? If you will try to cram it, it will come a bit late. So when we visualize the answer in our heads, we'll get to know what are the things that we don't understand and what was the one thing that we were not able to repeat. Remember, we don't have to remember everything word by word. We just have to understand and remember the concept. We are bound to forget the things that we read, and that is how our mind works. When we visualize the things in a story format, we are going to remember it for a longer duration. Repetition, revision makes it permanent. Many times we try to hide things from our friends that he will be performing better than me. No, that is wrong. Take the help of your friends. This is a pro tip. Remember how when we were kids, Our mothers used to ask us to recite the poem, which we still remember now. Let us bring the time back again. Ask your friends to ask you questions and you try to answer them out loud. This is one thing which will surely help you a lot. I have tried it. You should also try. You can create hurdles for yourself. Put yourself in a tighter position than you will be faced in the examination. For this, give mock tests. Suppose if you get 3 hours for your exam, try to do the whole entire exam in 2.5 hours. Try to solve the last test question papers with good diagrams and good handwriting. This will help you in time management. The time you will save now will be the time that you can use in your exams. You should be making short notes which will help score good marks in theory. While studying, prepare some short notes, charts or pictures, keywords from the topic and note it down in one place. Get your study material xeroxed and put the notes on the back of it. That out of this whole page, at least these are the highlights that I should remember. You can use blank space that I told you, and the time of exams you'll have a compilation of quick referral notes of your own, which will save a lot of time during your preparation. This is my last slide, the marking pattern. What usually the good examiners do is that before doing the marking, they read 4 or 5 answer copies. Then only they start to do the marking. If you have answered the question, as they know now what the whole class is writing, they'll give you 50%. So out of 10, you get 5. But if you have written it in a nice way, legible way, and a good handwriting, arrangement is good, then you will be getting 60% marks. Only the handwriting of the same answer will give you slightly more marks. In the same thing, if you will draw a diagram, and the diagram is neat and labeled, you can get 70% marks. But if it is bad handwriting and just scribbling of a diagram, the examiner knows that you know the subject, although you have not written, he still wants to give you 50% of the marks. You want to score high, so draw a diagram, color it, neatly label it, and the pages should be having good handwriting. You will be getting 80% of the marks. You must be thinking how to get full marks. Well, if you will supplement your answer with the recent advances, and you will also cite them, then you get almost full marks. So cleanly written answer copy, a neat label color diagram with recent references from the journal. What else can a child write? He'll get full marks. But remember, if you answer wrong, then maybe a lenient teacher may give you 2 or 3 marks. But if you don't answer, you don't get any marks. And so always sit, listen to the question, remember to your 3 years, see that what you had learned and how what is coming, you write something, maybe incomplete. Even 1 or 2 marks are better than having a 0. So that is the marking pattern. And with this, I've given you all the tips which I feel are important to approach a theory examination. So the day you enter, it is your hobby. You'll start learning. You'll go for your books. You'll go for your writing practice. You'll use a logbook, make notes. And maybe in the first attempt, you'll be coming back. Thank you.
Sir, thank you, sir. Such a nice presentation. And I think the PG students will definitely take advantage of what you have said and what you have projected. Sir, I would like to request you to give some more ideas about exactly the first year student who has just joined, because they are very raw. They don't know about orthopedics. They think that in ortho we have to read very less, and when they come across vast number of books 2 to 3 inches thick, they are lost. They have to start.
Actually, when the first students come to my department at IIMS Raipur, I usually call them to my chamber. I open my website, I show them, this is your curriculum, this is your syllabus. I
Right.
read it out to them. Next thing, what I have been emphasizing is a logbook. And every week, the boys, what they have done in the whole week, they write it and describe it. It is not just I have done 2 dressings. What they have seen, what they have read, that comes with the diagrams. And I have been emphasizing to all the people that if you are doing something, open your Campbell and read it. Open your textbook and read it. And then only you can do justice. And my boys are happy.
Great, sir. Sir, when should they start notes making? Either notes making should be based on text reading or question bank looking into it, the question bank.
So MS Orthopedics course, as we see it, is a self-learning course. Basically, there is no time to read. Basically, you are working in the wards. You are working in the OT. You are doing emergency duties. So it is reading with your work. You have to enjoy your work and keep on going. Just like I told you, you enter the ward, you pick up the betadine, read what it is, and try to speak. This is
Right.
betadine. So once you speak those 5 sentences, you know you cannot speak 5 sentences about betadine or intracath or a syringe or a bedsheet. Even for the implant section, implants, to take out a conscious nail, you cannot speak. So it is when you will think that I am not able to speak, you will yourself read the book so that you can come out with those 5 sentences. And that is the basic learning, where the desire comes from inside. That if my junior will be asking me, what is this thing, what will I say?
Thank you, sir. So now the floor is open for any queries or any new concept.
Alok Agrawal, sir.
Sir.
Like in medical college, where the study programs are more structured, many of our postgraduate students are doing DNB. Do you give any special instruction or tip for DNB students?
The total difference between a DNB student and an MS Orthopedic student is that the DNB student is with a particular consultant, with a specialization. He may be doing joints, he may be doing spine, he may be doing orthoscopy. He's a consultant, not a basic teacher. So their exposure becomes limited. And here it becomes more and more important that they join PG teaching courses, they attend conferences, they go to the other units and see all the work, and they go for self-reading. As a PG, I had read the whole Campbell before giving my examination. I don't know whether others can do that. But if you are reading the case, out of the 3 years, you get so much to learn that the whole course comes covered into it.
Alok sir, when the PG should join the medical college different PG teaching courses, it's in 2nd or 3rd year. When should they orient more?
So in the first year, even if I say that to attend PG teaching courses, the practical thing is that the seniors will not let them leave the wards. But they have to make a rapport with their seniors, where they will ask, sir, how to go about this, even how to wash my hand, what are the 5 steps, how to do for painting draping, why I am doing it in this sequence, what will happen if my swab is having more betadine falls down on the patient's body. So they will ask, the senior is very happy. The senior will be actually being the actual teacher who will tell them how to hold the knife, how to hold the artery, how to put the stitches and everything. So that is the training which comes in the first year. Once you are in the final year, you are busy now that my thesis has to be completed. I'm writing more and more cases and thesis has to be written, no time to there. You are searching here and there. So then you are forced to go to 1 or 2 courses which your HOD tells you. Basically, actual reading will be coming in the 2nd year when you decide, okay, now these are 3 books, Mercer or Turek, Campbell's Operative Orthopedics, and these others. So I have made it January Campbell first volume. February, Campbell second volume. And this will be how the revision will be going. Then only you will be putting all the pages out and at least seeing. Maybe you are not reading, but daily if you are doing one of those things, so you get to know what is given in the book. That is also too much, sir. But boys are doing, they discuss. They have to ask each other, do you know what are the osteotomies for the foot? So obviously you will say, I am to always discussing neck osteotomies. So what are the osteotomies in the foot? He'll open the chapter and he'll find there are so many ways to do, even small things. So that is how it is. You have to speak to your friends. You read and tell them what you have read. And they will tell you what they have read. Your colleagues are not your competitors. They are your biggest supporters and teachers. Degree is same. There's nothing more to win or lose. Thank you.
Okay, sir. Thank you, sir, for such a wonderful presentation, sir. Now I would like to invite Dr. Birendra for moderating the next scientific program.
Yes. Good morning, one and all. I'll be moderating Dr. David Chatterjee, sir. Few words about Dr. David Chatterjee, sir. He is acting as a professor and head of department in Department of Orthopedics in Bardhaman Medical College. And one good thing about him that he passed from the same college, the MBBS, in 1986. And he did his MS Orthopedics in 1993 from Institute of Postgraduate Medical Education and Research, Kolkata, and served his period as assistant professor from Bankura Sammilani Medical College and Calcutta National Medical Colleges. And after that, he promoted to associate professor and worked as a Calcutta National Medical College and BC Roy Polio Clinic Hospital for the crippled children. And after that, he worked as a professor in Bankura Sammilani Medical College again and NRS Medical College, Calcutta. Such a good journey about him. And now he is examiner of MBBS, MS, as well as DNB also in different institutes of the country. And Honorable Secretary, West Bengal Orthopedics Association between 2012 to 2015. And he has several papers in international and national orthopedic journal. Now, I would like to invite Dr. David Chatterjee, sir. Please deliver his lecture. Dr. Debdutta, sir.
Good morning to all. Am I audible?
Yes, sir. Please.
Thank you, Dr. Manish and Jharkhand Orthopedic Association to invite me in the galaxies of such a webinar. I'm really grateful to them. And moreover, I am very much, Dr. Agrawal has made my work very easy. He has explained all the things what a postgraduate student should follow. The scenario is a totally bit different when we did our postgraduate course, and in these days, it is expected that it should be changed, and it has been changed. Now, and what is my concept? That is what is expected from the postgraduate students while managing patients and wound care in the wards. Now, our expectation from the postgraduate students, that is, expectation is one side and the reality is in another side. They must be rational and confident while managing patients and wound care in the wards. These are the two things, that is the how to manage the patients and how to take the wound care. Now, we all have realized that to learn the art of clinical practice is needs a long learning curve. Should be, and it is actually for the lifelong. Unfortunately, but it's in my observation that it is now become a fading art. It should not be neglected. that is clinical practice, is the clinical art. Learning the clinical art is the utmost importance during the postgraduate tenure. Now, our motto is how to satisfy a patient and also to pass the examination nicely. Now, for the juniors, please remember that all conditions are not curable and all the patients will not take the same course. You can remember, this thing that Sir William Osler had said, that medicine is a science of uncertainty and an art of probability. This is simply true even in these days, what in 1884 Sir William Osler had said. Now, actually, it goes that is in the center. Our focus is on the patient, and in one side lies the team that is of the surgeons, that is the doctors, nurse, and the paramedics. And on the opposite side lies the patient party. They are very much anxious, and lies the information desk. And on the other side, nowadays, the insurance companies and the media. Be very careful about them. And we have to. Now, this is a practice for a postgraduate student under the umbrella of the several faculties or the institute, that is to how to maintain the balance amongst all these factors. Now, it needs patience. It should be grasped from the very early period of the training. Now, I should advise that try to learn it from everybody around you, not only the seniors, the juniors, and the non-medical staff, even from the patient party, how to talk with each other, how to behave with each other, and how to deal a problem. Now, every institute have a institute protocol, unit have a protocol. It is always a rational thing. Please try to follow the institutional protocols. Like that of in many of our, that is a home protocol. We, on all the families, we have some protocols. That is we have to do such and such. What your father or mother or parents gives you advice from the very early period. So think your department as your home. Thereby, you will be very comfortable for the during this tenure. Now, that is the advice from the great persons, that learn all the tricks when you are young, but learning never ends till our life ends. Now, Dr. Agrawal has nicely said, very nicely said, that listen to your seniors carefully during the ward rounds. And again, I should say that follow the institutional protocols. Clear your doubts. Again, I should quote Dr. Agrawal, that he has said that don't hesitate to ask questions to the seniors. Keep a notebook with you. He has nicely shown it. That is a note. It is a very, very important. All things not should be kept in mind. Please keep a notebook and note down the important directions and important points which will help you lifelong, not only in examination. And complete your work after the round. Mind that unfinished work means work not done. And clinical perfection is the motto of this tenure. And clinical perfection is only possible if you first examine the patient carefully, go through the books. You have seen that Dr. Agrawal has shown a lot many books. These are the very basic and very the books we can enjoy it, very nicely written. These are the gold standard. So examine the patient carefully, go through the books, present it regularly near the faculties. You examine the patient or even wound and go through the book, and you present it near the faculty regularly. Thereby, it will clear your doubts. You will get nicely prepared for your exam and also for your future life. I can again quote the great master, Sir William Osler, what he said in 1884, that to study patient without books is to sail an uncharted sea, but to study books without patient is not to go to sea at all. So these are all complementary. You have to balance between these two. Now, examination of the wound proper. Now I'm coming to that. We, from the very childhood, we have seen that Arjun pointed out that is he had only seen the eye. But we, the clinician, we should not focus only the wound only. That is, in every round, in every time, you should look at the patient. This will say you everything. It is a book. Patient is a book, and not the wound only. So look at the patient. Wound is a part of it. So examine the wound also. So don't focus on the wound only, but look at the patient. What the patient, how the patient looks, what the patient tries to say. Please listen to him. Please examine him. So every time you listen to the patient carefully, and please, even a very simple procedure, please explain the procedure and why are you going to do. They are afraid, they are apprehensive. So you get confidence from them. Wound care. Remember, if you have to, how to deal with the wound, it is very important that we are always bathed in the ocean of organisms. We are always fighting with the different type of organisms. But mind that hospital organisms are more dangerous than the street organisms. Like that of there is a prisoners which are behind the bar are more dangerous than these street organisms. As because this nosocomial infection, it is very clear to all. Now, examination of the wound. Now, in any junior, the first thing comes in mind, when I should examine, where I should examine, and how I should examine. Now, when, if you see there is any soakage, number two, the patient is having any discomfort, number two, for removal of stitches, when to do it? Today, tomorrow, never. It is not today, but immediately. That is today. Now, where? The question comes where? Preferably in a sterile suit, in sterile condition. Now, how? Now, you don't go only in a single-handed. It is not possible. You take at least 2 assistants and have a very good hand hygiene, as because underneath the nail and underneath the nail is the most dirty portion of the body, or one of the most very dirty portion of the body, one of the most. So you must try to, most of the juniors do not know how to how to maintain the hand hygiene. This is a very, very important, Dr. Agrawal has said already. And try to grasp the non-touch technique. And the best solution, that is to wash any wound, is normal saline, normal saline, normal saline. It is not any chemical. Any chemical is irritant to the tissue. So try to be in normal saline. That is the most acceptable solution in the cleaning the wound. Now, antibiotic ointment. Different types of antibiotic ointments are present. If you have to use the commonest antibiotic ointment is the micopuricin, you can use it. And regarding systemic antibiotic, please don't, this is a misuse of systemic antibiotics in different institutes. We have a wrong concept. Please go through what should be the systemic antibiotic. If you have to use different operative procedures, have different antibiotic regime, don't misuse it. So it will create problem for the patient, and also unnecessarily it will create the resistant organism, and it will make the condition in a messy one. Now, sterile gauge, you have to use it. How to take that sterile gauge is also a technique. Take the corner. You will learn from everyone, that is your seniors, sterile cotton, and how to make bandages. Is it bandage? How to make bandages, how to apply the bandages. It is also a very important art in the amputation stamp. how to make the bandage in the shoulder, how to make the bandage in the elbow or knee. It is a matter of art. You try to learn it. It is not, it looks easy, but it is difficult. It needs, it learns learning. So try to learn it, very easy. And one thing, while you are going to go for a, dressing, that is the wound examination, never to forget a photograph of the wound, as because during subsequent round or during discussion, you, without removing the dressing in the word, you can show it to your seniors that, sir, this was the condition of the wound. So it avoid contamination. Number two, also, it also very important for documentation. When you will present any paper or present any report, even in the law, it is very important documentation. That is, take a clinical photograph. We have all with the mobile phones. We can take a photo instantly. But mind that, never disclose the identity of the patient. Now, drain. You can see this background, this back. This it is needs again a very technical job. You have to learn it, and it is very easy. It's a very commonly used nowadays. It's a very helpful one. And so you must know what to do in the word and what not to do in the word. So you do and don'ts, like that of in our home, what we do and we don't. So you can remember these 10 things, what we are learned from the very, taught from the very beginning. That is, be punctual, try to be punctual. Your dress, you must be well dressed. That is a dress protocol. You must maintain it. Sometimes the casual dresses creates a very bad impression for the patients. But nowadays, fortunately, all the hospitals having some dress code, we have to follow it. And impressed by your behavior. That is, don't get irritated. Don't get this type of behavior is not acceptable for in our profession. Learning and execution. Learn and execute it properly. Professional honesty. Don't make any loose comment for in any condition, for any condition. Actually, it is said that you are dealing with a problem. If you make any comment, it will produce another problem. So to go for a single solution for a single problem, don't try to create a second problem. So it is very, very important. You must have to keep your brain very cool. That we should not. We are in a very, very bad time nowadays. You can see the different type of violence are occurring. It should be learned from the very beginning how to resist it. Now, correct and timely information to the teammates. Dr. Agrawal said that is a very important. This is the communication. That is you have to communicate your seniors, your and all the teammates. Not only that you also inform that is the sisters, that is the nurses in the ward, also paramedics, and also the information desk. That thereby the patient party can get proper information about the patient. And record keeping, it's a very, very important thing. We have seen that how Dr. Agrawal was eagerly taught you or told you that is how to make a record keeping. Is a very, very important thing. And go through the books. That is, the books are very important. You have to see, read, and again read. So this is a very important thing. Presentation to the faculties. This is another very important thing. You every day, a simple thing for 2 minutes, 3 minutes, 5 minutes, even in the ward rounds, you tell to your seniors that, sir, I want to present in such a manner. I want to describe the thing in such a manner. No one will object you. All will accept you. But unfortunately, this type of attitude from the PGTs are nowadays very much lacking. Now, paper presentation and all these things, if you keep a record and if you go through like this, you can make a very good paper at the end of the day, and you can present it in a different scenario. We have many patients in a different presentation. We are missing, we cannot see them, we cannot record them. So try to present this. And another important I am missing, that is you try to teach the juniors. That is, you try to take some classes in the evening to the juniors, undergraduates, your junior students, and It will help you, your pronunciation, your presentation, and your clear your doubts. And after that is a, suppose you want to present a case on the tomorrow morning. You on today in this evening you try to present it. You try to be a teacher to your juniors. Yeah, this is the case. This will create a very good impression and very good learning method. So this case study and discussion is a very, very important thing, as because orthopedic residents has to go for a very busy schedule. It's a very little time to go through the books, but nowadays is very helpful. That is, we have all this cell phone, and the books are being in the software. You can, in the software, you can see the soft copy there. Now, wound care. I have said that see the patient as a whole, not the wound. Maybe very sick, maybe having some complaint. Listen to the patient and explain the procedure and sterile technique. Look at the wound. If there is any smell, try to smell it. There are different types of condition rarely may present. It give you a clue that this type of organism may be present there. And take a photograph and wash with normal saline. Antibiotics, I have already said that local antibiotic or systemic antibiotic, and cover it with a sterile gauze, or even if liquids are drained, you go for a vac or whatever your consultant has said, and keep proper notes. Please don't forget, and immediately you should keep the proper notes. And preferably when you are taking a photograph, you can make a diagram that Dr. Agrawal has nicely described it. Now, it is a very light slide. I think that postgraduate students, when come first, that is a first year student, I think they are like a sapling. That is, the seed has grown from it. Or, in other words, a newly married lady has come to our house. That is like that of, we have to be like the father-in-law. That is your daughter has come to you in a different manner. So she doesn't know what are the protocols, what are the things I have to do, what are the things. So you have to be very affectionate and very rational to explain her that these are these things you have to do. So this is a very happy moment for any department to have the new PGTs. And nowadays we are getting PGTs from different corners of the country. So we are very happy with that, which is a brilliant and very helpful, and we can learn from them. I not should say that we teach them, but we learn from them. That they are very much brilliant and they are very much having different types of culture. We can rectify ourselves by their very good things. So think first year as your sister, newly married, she has come to your house. Now second year, now they have now adjusted. Now it is like a young plant. They are ready to give fruits. That's a 1 year. This is a tough schedule. And I should not say that, don't take it otherwise. I should say they should be we are expecting a very good delivery. That is, they should be rich with the knowledge. But there are some black horses. That is, some candidates are at a high risk. So you have to rectify them. So it's like that of high risk pregnancy, there are high risk students, I should say. Now the final year is a mature plant. We expect that is a good quality and good quantity of fruit from the tree. That is, or a good delivery. That is a good sibling. That is a good thing from the, that is a good result. And a good person, good surgeon with a good manners, he will come out from the institute. So in summary, try to utilize, to my juniors, try to utilize your tenure honestly. Don't make any loose comment. Always remain in the race of learning. You attend the workshops, you attend the classes, never miss the classes. One missing any class means you are losing a lot. So everything, and wound care is an art. Try to learn it from everybody in the world. They are very much experienced one. Students are the future of the nation. So a good student can make a good nation. So the world will remain safe. We shall remain safe if they get properly trained. So thank you. Thank you for your patience hearing.
Thank you, Chatterjee sir, for such a clarification and utilization of your talk must be by the DNV PGs always and the PG of orthopedics PG. Sir, you said very right that you maintain the balance between teachers and seniors, between the patient party and whatever medical record you have. Sir, can you just a bit words regarding how we reduce the medical error records?
I can't hear you.
How we should reduce the medical error records, like in during the round, during the notes, during keeping all the notes in the round book, how the PG decreases the medical records error.
Okay, okay. Actually, this is a tradition or that legacy. We have to maintain it. That is the first thing. That is the second year should write down. Second year should write down the notes during the ward rounds, and they all will after the round. It takes a time, hour or 2 hours. They have a refreshment. After that, they should come back to the ward and taking the BHT. They should note down all these things. I have said that it should be done immediately. Work done incomplete means work not done, and they should rectify it and they should show it to the senior resident or I mean the assistant professor or even a professor. They should not hesitate to go to the teacher. Say, think they are like their father, their uncle, their all these things, the family members. If any PGT, if it is my message, please. It is any PGT. Think the department as his home. There will be no problem. So there is will no constraints. That is a very important thing. You want peace. The hospital is like I mean community. We are all every faculty are always helpful. We have nowadays a very easy thing, that is a WhatsApp and all this. Even at midnight, we get our phone is always open, so we get a call from the senior resident, sir, such and such an wound has come, injury has come. What to do? Even without visiting, we can see the this video call and we can say, do these things. This is a very important thing, and I think that you please complete. My advice to all the PGTs: please complete your work. What you are doing, please complete your work. Incomplete work means work not done. This message should be kept in mind.
And always show your work to the seniors and check the records.
Yes,
sir. Sir, regarding the time spent in ward by the PGs, the first year practice is different, second year practice is different, final year to pass and get out. So how do you have any message to the PGs that first year, second year, like the time spent in the wards with the patients?
No, actually, it is said from the when we were students, we have been taught that students unrest should remain unrest. That is a young period; they should remain unrest. I am not talking that, but telling that the thing is that if they think that I have worked a lot, if they think this is my time period, they will get lost. This dedication is needed for this 365 into 3. That is the 3 years. That is dedication is without dedication. No one will be able to achieve. There is no shortcuts. So no time limit. You have to spend even at night. We enjoy the emergency. In our periods, we have worked for 2 hours or 3 hours continuously. We went to the canteen. We take the tea, coffee, or anything. We came back and again we have that. Sometimes we are tired. You take rest. We are coming. So and this time we can enjoy. We can recall the time, our good times while working in the ward. If you cannot enjoy the time in the ward, you will not be able to. Coming in this fashion that I am time bound. It is 6 o'clock. I have to go. It is not like that. So these 3 years must be utilized, must be enjoyed. How to enjoy? They should try to realize.
enjoy, present the paper, present the patients in the ward regularly. Yes,
Yes,
enjoy
yes.
also and present the patient, present the paper presentation, publishment like that.
Yes, yes, that is the important thing. If they keep the proper records, if they keep the proper documentation, that is a photograph and all these things, and if they present on the next day they will be able to see the what are the faults here. Use make and say they should every case they should this interesting case they should keep in a PowerPoint presentation. That is a keep it in and on the leisure time they should make it and show it to the department. That is that is a clinical meeting. That is every I think every department has a clinical meeting in the end of the week, so we can see them. We can rectify them. These are the mistakes. These are the things you have nicely done. If I would be there, I would not be able to do these things. So they have to encourage and they also give suggestion. These are the mistakes you have done, or these are the things you have nicely done.
Dr. Virendra, we are not audible. Kindly unmute yourself. Okay, sir. Till time he won. David Chatterjee, sir, one quick comment. You have wonderfully explained the 3 years. First year is like newly married going. Second is pregnancy with knowledge. And third is mature with sibling. Wonderful, sir. I have not seen something like this, sir.
Yes, yes.
Over to you, Dr. Virendra.
Yeah. Thank you so much, sir. Chatterjee, sir, you have cleared everything. Sir, one thing I'd like to know from the PG sides regarding wound examination and capture all the pictures of the wound and make it daily record. Sir, many of the times, first year is more regarding the wound dressing and cells. When should they inform or involve the seniors regarding the dressing in all comorbid patients or in normal patients also? During the post-op dressings or any trauma cases?
Actually, the thing is that when they comes new, that is on the first year, when they joins new, we used to sit them, we used to give them what is the protocol of our institute, what you should do, what you should not do.
Yes.
And even when they are doing something, if you are in a problem, stop there and inform your senior. We are there, anyone is there, even we are not in the campus, you can show this, sir, this is the thing, what we should do. Don't jump on, don't go for any adventurous procedure. So this is a very important thing. I should always ask my PGTs to follow this.
Yes. Thank you, Chatterjee, sir, for such a nice explanation regarding all the queries and delivered a good talk. We also enjoyed and we also have learned as a faculty. And now I am moving to the third session, sir, if you allow. Saubhik, Dr. Saubhik Das will take the third session, moderate the third session. Over to Dr. Saubhik. Thank you, Chatterjee, sir.
Thank you. Thank you.
Thank you, sir. Good morning. I'm very happy being part of this webinar series for the PG students mainly. So in the third session, I'm very delighted and happy to have Professor Dr. Harpal Singh Selhi, sir. And he's a stalwart, he's a orthopedic surgeon and academician, very well known. He is currently the professor in the Department of Orthopedics at Ayan Medical College, Ludhiana. He was the past president of Ludhiana Orthopedic Association. He has authored numerous publications and book chapters. He is also the AO faculty for trauma courses since 2004. He has done many specialized fellowships, namely in Switzerland, Australia, also in National University Hospital, Singapore. And he was also a postdoctoral fellow in Johns Hopkins Medical Center, Baltimore. So in the next 30 minutes, we'll know, the PG students will come to know his thoughts on what are the requirements the PG students should have while managing an emergency. So we are delighted to welcome Professor Dr. Harpal Singh Selhi, sir. Over to you, sir.
Thank you for the pleasant words. In my opinion, as yet, I'm not a stalwart. That's a very big word for someone. Like you said, let me first, since it's all about postgraduate students, let me tell you one thing. Let me begin with it that when I started my residency way back in '94, the orthopedic residency was the same as it is today. Most difficult to get in, most grueling of the surgical residency programs. And it tested you both physically and emotionally. Financial challenge kabhi hota hi nahi tha. Reason is you never have time to spend money. Well, if you ask me, those 5 years, 3 years as a senior, as a resident, 3 years as a senior resident and some fellowships, those times are blank with me. I lost touch with my friends. I lost touch with some of my family members and acquaintances. I'm not saying that that's the way to go. I'm just giving you my insight, how I trained or how people of my age trained in orthopedics. And that was the norm. It's not that it was different for me. It was the same for everyone who was a resident during those times, bearing few exceptions. That was the rule when I say that. So proceeding further, it was my sojourns or fellowships gave me the opportunities to work out of India. And to be very honest, few of the places that I visited, the chiefs were exactly the way my chief was. And I have been to the hospitals where residents were timed. When I say timed, they time you from the time you get a call and how long do you take to reach emergency. That could be middle of the night, that could be evening, you could be out with your girlfriend. On a lighter note, let me narrate you an anecdote. I got engaged during my residency. My better half is a doctor. She's now herself a professor of pathology. So the first time I took her out for dinner after we got engaged, I took permission from my chief that can I go out for dinner, and I was granted permission. In those days, there were only pagers. We were having our meal and I get a page from my chief, call back immediately. So I called him and I was fired left, right and center that why you're not available in the hospital. There's a patient sick in the ward and nobody's attending. We left the food at the restaurant and said, if we come back, we'll have it. Otherwise, do what you want. I rushed to the hospital. She was sitting in the car. I attended to the patient for 1 hour. Chief also came in because the patient was sick. And once the patient was stabilized, I cheekily asked my prof that, is it okay if I leave the hospital? He says, why? And I had to tell him that I was out for dinner and my fiancée is sitting in the car. And then I got fired again for this. भाई आपने छुट्टी ली थी, आपने हमें बताया क्यों नहीं, याद क्यों नहीं कराया अगर हम भूल गए. Means they had nothing personal when they were upset. The only thing in their mind was patient care. And that is what we learned from them. कि patient is the prime focus in your life. या तो patient लेना नहीं है, ले लिया तो वो prime focus है आपका. Now, just proceeding with the formal lecture, as part of the organizing team of IACON 2022, and I also am a scientific chair in the same conference, I will take this opportunity to invite all of you to Amritsar, the city of Golden Temple, in November, December for our flagship event of the national body, that is IACON 2022. We will leave no stone unturned to extend you the warmest possible hospitality mixed with the best possible academics. So please register and submit your abstracts. Now, who is a great resident? सबसे पहले क्वेश्चन आता है सबसे बढ़िया रेजिडेंट मैं कैसे बनूं? When I was a resident, that was it. कि बॉस को खुश कैसे रखना है, या मतलब how to keep everybody happy and keep your patients also happy, keep your chiefs also happy. One thing that we have not discussed in the number of lectures that have happened is how to keep your paramedical staff happy. You know, nurses and your dressers, your ward boys are the cornerstone of your residency. If they are happy with you, आपका आधा काम तो वैसे ही हो जाएगा. So that's an art that you need to develop. Don't think nurses are below us and fight with them. They are equally part of the team. You know, वो जिसको कहते हैं ना हिंदी में धंधा फंसेगा तो गरारी घूमेगी. So they are also part of the wheel. If अगर उनको ब्रेक नहीं लगाने देनी तो उनको make them part of the wheel and do it. So is it competency or is it something more than that? Communication has already been taken up. I'll just briefly summarize it. You need communication with the patient, communication with the family, communication with your colleagues, communication with your attending consultant, and communication with your paramedical staff. Now think of it कि कितने लोगों का काम आपको करना पड़ेगा, but that's what it takes. Behavior, of course, how you behave yourself in front of the patient, with your colleagues, this all matters. If you address your junior in a bad way in front of the patient or his attendants, don't think they are only thinking bad about your colleague. Next, you are in line. And I'm not saying that you be formally dressed up with a tie and everything, but you should be decently dressed up. Now, decent is for you to decide what is decent, but don't try to copy. You know, I've seen a lot of people trying to imitate what happens in the West. But let me tell you very clearly, I've worked in the West. It is not a hearsay. You cannot interact with the patient or with the family if you are not formally dressed. I worked in one of the departments where you had to change back out of the scrubs into your clothes, which meant a tie and black leather shoes, talk to the family, come back and change again for the next case. Now, I'm not saying that's the norm, but that's one extreme. The other extreme is that a resident walks in kurta pajama with chappals, kanchi chappals into the OPD. That's not done. Now, I might sound a little chauvinist. I've seen a lot of females with their hair open walking into the OPD. See, ma'am, this is not a catwalk. This is not a fashion show. You are here to examine patients. You'll have to bend forward. You'll have to bend backwards. You will be couching on. You might be bending on the couch. Please be decently dressed. आपको जो respect होती है is never demanded. It is commanded. And the first impression is the last impression. OPD का patient आपके पास सिर्फ 4 या 5 मिनट के लिए आता है. Unless you are properly dressed. Now in emergency, when you tackle the patient, you are the first person to talk to that patient. If you are not properly dressed, they won't even consider you as a doctor. Right? So this is part of it. Now, is it competence, behavior, and then other things? I think if you're working in the emergency, the number one is availability. If you're posted in the emergency, you just can't leave emergency and say, मैं खाना खाने गया था, मेरा brother आ गया था, मैं उसको coffee पिलाने गया था. Availability is for the time you are on duty, whether it's an 8-hour shift or a 12-hour shift, except to attend nature's call, you got to be in the emergency. Because a patient with a vascular injury, patient with a severe trauma will not inform you before coming into the emergency. This is not Europe or America where you'll get a call beforehand that the helicopter is landing. The patient, they will open the ambulance and you don't even know what kind of patient is inside. Next is behavior, because you are the first point of contact on behalf of the hospital, on behalf of your unit, with the patient and their family. How you talk to them, how you present yourself to them makes a lot of difference. Third comes competence. अगर आप अवेलेबल हो, आपका बिहेवियर इमरजेंसी में अच्छा था, पेशेंट को आपने टैकल कर लिया, उनको नहीं पता आप कैसे डॉक्टर हो, दे डोंट इवन नो वेदर यू आर अ रेजिडेंट और नॉट, उनके लिए आप डॉक्टर हो. Competence, except for few things, you can always seek help in next 5 minutes. If you're, of course, if you're a resident, you're working in a teaching hospital, you will have 1 year senior or a senior resident or a attending consultant available on call, or you can discuss ki sir ye cheezein hain, aage kya karna hai. So behavior is that important to me. If it was not ABC, I might have put behavior on the top. Now, if we look at literature, great resident is the one who is trustworthy, who is hardworking, and residency program in any subject, and more so in orthopedics, like it has been stressed by previous two speakers, you are a self-learner. You have to be detail-oriented, because the patient in the emergency won't come with a diagnosis. If you miss out the details, you might lose the patient. You have to be very efficient. Polytrauma ka patient, you can't say, sir, I was managing femur, I am humerus to maine dekhi nahi, or I was managing open fracture tibia and I missed out on the spine injury or a cervical spine injury. You have to be efficient to tackle everything in one go. You might have more than one patient at the same time. And of course, you should be personable, presentable, right? Last but not the least, and rather very, very important, is you have to be ethical with the patient. That's very, very important. This is the perspective from the literature about a great resident in orthopedics. These are published things. These are not my own. So what do I expect from an orthopedic resident in emergency? You need to assess and evaluate the patient. Please, I'm not saying any bone, any joint, any wound. Evaluate the patient as a whole. Treat, don't look at the broken bone. Look at broken bone in a person. Look at a person with a broken bone. What should be your action? Stabilize the patient first. Don't rush after the fracture unless it is actively bleeding or there is some really that kind of emergency. Look at, stabilize the patient. Try to understand what injuries the patient has. Treat patient as a unit, not fracture as a subunit. Communicate with the family. Do your first quick, fast assessment and communicate to the family what you have evaluated, so that they know firsthand right on that time कि patient को है क्या है, so that they don't bother you again and again. उनको काम करके you can make them sit on a side and say, let me work on the patient, I'll come back to you after I do a detailed examination. That way they will form a bond with you. Trust abhi nahi aayega, abhi sirf ek bond ban jayega. There's a communication channel now you have with, and you will know who in the family is the inverted commas the boss. Is it the father? Is it the brother? Is it the brother-in-law? जो सबसे ज्यादा overbearing होगा, you start communicating with, take that person on your side, right? Then do a detailed assessment to reach a diagnosis. Once you have reached a diagnosis, again communicate with the family. कि अब ये लग रहा है, पर मैं अभी इसके टेस्ट करने लगा हूं, टेस्ट हो जाए फिर मैं आपसे बात करूंगा. And next thing, there was a lot of discussion कि how to tackle the overbearing family members and friends. Best is उनको बोलो फॉर्म भरो और 4 ब्लड के फॉर्म पकड़ा दो. 2 things will happen. Half of them will disappear जब ब्लड का नाम आएगा, और जो सीरियस रह जाएंगे उनमें से एक बंदा आपके पास रह जाएगा, बाकी all will be going to blood bank to donate the blood or arranging from the blood. So now you, instead of tackling a crowd of 10 people, you are just tackling 2 or 3 people. Now, once you have reached a diagnosis, you know what tests to request for, investigate the patient on emergency lines, right? Now, once you have sent for the investigations, you have stabilized the patient, you have communicated with the family, now is the time to document everything. You must document all the injuries, draw your diagrams, put in photographs, whatever you want, document, and document even that you have counseled the family. अभी साइन कराने की जरूरत नहीं है, अभी सिर्फ डॉक्यूमेंट करो. Let them come back to you and that is the time कि अब मैंने आपको काउंसिल कर दिया जी, एक ये फाइल पे साइन कर दीजिए. Because now you have a bond and they will start having trust. जब एक्सरे आप करोगे, एक्सरे में दिखाओगे फ्रैक्चर है and you had spoken about a femur fracture, now that bond of communication channel is slowly getting converted into trust. If you ask me, in an ideal orthopedic resident in emergency, I would say every one of them should have done a ATLS so that they understand what are the injuries and how to tackle them, how to proceed with the polytrauma patient, right? So what are the other qualities? The orthopedic resident should understand orthopedic implants because he's the key person who has examined the patient firsthand. He should know what kind of fracture or injury he is looking at, what kind of injury he's expecting, and what orthopedic implants need to be ready in the OR when this patient goes to the operation room in case of an emergency procedure. Communicate with the family and the patient, the likely implants that are required, what is the cost factor of the surgery. Don't try to shoo them away. Try to be empathetic towards them, that this is the cost. Give them options. We have the best of the best and we have value for money implants also. Don't try to condemn the cheap implants. Don't try to make them guilty that they are not able to afford the top-notch implant for the patient. Communicate with the vendor what all you require and how soon that should be ready. And this should be in turn communicated back to your team that I've spoken to the vendor, spoken to the family, and this is what is required from my side, and this is what I've ordered. Again, document this thing again, that the patient demands the best of the best or patient demands value for money implant. Now, again, I'll again come back to patient assessment. Don't go for wound assessment or wound this, wound that. Go for patient assessment. Next comes wound assessment and management. He should be able to tackle the wound, irrigate the wound, do a proper sterile dressing. Compression bandage is an art and science which every orthopedic surgeon resident needs to learn. Because in limbs, it is the compression bandage which saves us from blood loss. Slab application with proper padding, and also understand that polytrauma victims will not complain of pain if the slab is too tight or the dressing is too tight. They need to have a knowledge. Here now it comes knowledge. Instead of action, it is knowledge. Ki what all things to monitor when he or she has given a compression bandage or a slab application. They must understand the protocols and follow it. If the department has protocol for certain injuries, they have to be followed. In addition, in a teaching hospital, many theses are based on trauma or emergency admissions. They must know those protocols and inform their colleagues that such and such case has presented. I feel it is part of your protocol. Please come and have a look. One thing that I always noticed from the last few years that our residents are good in pharmacology, but they do not understand the application of clinical pharmacology because they do not understand the trade names. So understanding the application of clinical pharmacology is very important. I'm not saying that what we are taught, knowledge-based pharmacology is wrong, but clinical pharmacology sometimes differs from what we are taught. As we have said, bacteriostatic or bactericidal drug kabhi ikkathe nahi deni. But in clinical practice, it happens because of the culture-based sensitivities and has to be done. And orthopedic branch, even at the consultant level, at the senior resident level, at a resident level, and the resident posted in the emergency is a team play. And you have to be a team player. Unless you're a team, orthopedics is all about being a team. Because, you know, football is played by 11 people and with a common goal. And we all are actually players of the same team. We are less than 11, but we achieve the best of the best. We are not trying to put the ball in the goal, but we are trying to give life back to the patient as he would like to have it. There is a video on the YouTube. If the time permits, I'll just like to play it for a little while so that people understand what I mean when I say
Hi.
patient.
Hi. Are you the registrar of anesthesia?
Yes.
I need to book a case.
Who are you?
I'm the registrar of Orthopedia.
Sure. What's the story?
There is a fracture. I need to fix it.
Okay. Tell me more.
There is a fracture. I need to fix it. There is a fracture. I need to fix it.
Can you tell me more?
The fracture is very displaced. I need to fix it.
Okay. Let's start from the basics. Where is the fracture?
The fracture is in the emergency department. I need to fix it.
That's not what I meant. Who does the fracture belong to?
The fracture belongs to a bone. The bone is a femur.
And who does the femur belong to?
The femur belongs to a 97-year-old lady from a nursing home.
Okay. Anything else you can tell me?
She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for
what?
Her temperature is 29 degrees.
Right.
And her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
So, I often get a call from the emergency and say, Sir, ek PFN aaya hai. They won't tell you, Sir, hemi ke liye patient admit kiya hai. They are not telling me, is it a male or a female? Is it 65, 75, fracture neck femur or trochanteric fracture or displaced neck femur? Or patient has comorbid conditions like diabetes, hypertension, cardiac disease, or is a survivor of breast cancer. All they want to tell me is, Sir, ek PFN aaya, because that is what they feel they're gonna do it. So this is what I really think we need to change this mindset. And probably if I won't be wrong if I say this has percolated from us down. As a consultant, as a teacher, as a mentor, as a friend, you cannot disown this, that they started it and we had nothing to do with it. Because if they've been working under us for 3 years and they still communicate like this, we are responsible for it as well. So this part we already covered, team player. So if you ask me, has to be ATLS trained with a high index of suspicion for the complications like compartment syndrome, vascular compromise, should be able to diagnose the circulation, should know how to preserve the amputated part, and must understand the process of taking it and documenting an informed consent for every procedure that he or she does in the emergency room. That's very, very important in the present scenario, because without informed consent, we can be in trouble. The other thing is hand washing, surgical scrub has already been taken up. He must understand the value of sterile draping, protective gear for himself or herself, because he's part of our family. I consider orthopedics as part of my family, and protection of my resident is as important for me as it is important for myself. So they must understand, because they are young, they are sometimes brash, they don't understand the importance of protective gear, but we have to inculcate in them. A dressing can be delayed by a few minutes. A procedure can be delayed by a few minutes, but protective gear is very important. He should be trained, and that is where our role comes in, that before getting posted into the emergency department, he should have done supervised joint aspirations, splintage procedures, joint reduction maneuvers. He should know how to understand, interpret X-rays and imaging, because unless they understand how to interpret the X-rays, they won't know what to order. They must know clinical and orthopedic photography. Already been mentioned, because of the technology, now we can share the photographs. We can share the photographs of the wounds. We can share the photographs of the X-rays, but the identity has to be kept off, because that can form a problem. They must be able to form or chart a plan of management for the patient in the emergency. They should be able to communicate with the team. I cannot emphasize more by repeating it again and again, again and again. Communication is the key word, behavior and communication. They must have a logbook where they document every patient in the emergency that they have managed. At this point of time, they do not understand how valuable it is, but down in their career, few years down the line, I have had few residents come back and prepare a logbook, and then they come to me, sir, isko sign kar do ki maine ye patient manage kiye the. So I want to emphasize that logbook is the way forward. Documentation is the way forward. They must attend to the teaching program. Attending to the emergency cases being posted in the emergency doesn't mean that you skip the teaching program. A lot of things has been said about preparation of the exam. You know, resident and consultant is not a cat and mouse game or a animation film. It cannot be. You cannot force somebody to learn. वो कहते हैं ना, घोड़े को आप लेके जा सकते हो कुएं तक, पर पानी नहीं पिला सकते. So this has to come from inside. If I have to coax my residents time and again, कि पढ़ लो, पढ़ लो, पढ़ लो, there is something wrong somewhere, and we need to look at it. This is something where you learn on the job. Theoretical knowledge you'll gain by reading. There's no shortcuts to reading. Empathy has to be developed, and skill development is the practical knowledge that they get under supervision from all of us. We have to be on the same page with the same aim. One is patient care. The second is with the target that each orthopedic trainee working under us develops into a successful orthopedic surgeon. Here I'll again bring in my chief. Two anecdotes from my chief. His mother had an intertrochanteric fracture, and he had retired by then. His mother was 90. She's no more. And the chief at that time told me, Harpal, you go and fix the trochanteric fracture. So I did the reduction and came back and told, we both were, my chief at that time and me were both students of the same boss. I told him, sir, reduction bahut achhi aa gayi. He says, look, I have full faith in you. I have trained you. Go and do it. I'm not coming into the OR. Don't come back to me and tell me what is going on. Complete the procedure and come back. That is the kind of faith a chief should have in his trainee. He used to say, I've trained you like कि कल को मेरे को जरूरत पड़ेगी तो मेरा ऑपरेशन आप करोगे, मैं कहीं और नहीं जाऊंगा करवाने के लिए. And he got both his knees replaced from his own student, who was the chief at that time. So that is the kind of faith he had in his own training. It takes guts to say that, and more guts to get it done also. And I hope we all can match that level. So availability and appearance. This is from my friend Lalit Mani. It's not only availability, but appearance also. It is not only behavior, but body language also. Competence and knowledge will come at the third place. Documentation is very important. Ethics, we cannot say that they are any less. Another anecdote for the residents to learn, you know, I was a senior resident and one of my residents was putting in a Steinman pin without any clean and prep. So I told him, is this the way to proceed? This is how you're going to learn and show it to your juniors, how you do it? And the answer he gives me, boss भी ऐसे ही करते हैं. मैंने कहा जब boss बन जाएगा तो कर लेना, अभी तो सीधे तरीके करो. ग्लव उतार, दूसरे बंदे को हैंड ओवर कर. So it is important that you learn the right way and follow the proper procedure. Don't try to copy the chief. Chief has 30 years experience. We don't have it. So like, let me give you this example. This was the patient which presented and my resident says, oh sir, tibia nail hua hai, usme ek thoda sa wound hai. Culture bhej दूं? He is not assessing the patient as a whole. कि patient को problem क्या है? कितनी देर पहले हुई है उसकी surgery? Why has he come to the hospital now? Why is he not going to the index surgeon? No recent X-ray, no biochemical markers, no blood workup, and he says, "Sir, thoda sa sinus hai, culture leke bhej do patient." So this kind of communication is not good. You must assess the patient as a whole. Now, this is another patient which came into the emergency as a polytrauma patient. Now looks just a segmental tibia, right? But my resident told me, "Sir, I don't like the face of the patient. There is something wrong, something more, and the foot is cold." I said, "What about the pulses?" "Sir, abhi to BP bhi kam hai, pulses to nahi hai, but sir, kuch theek nahi lag raha mere ko." मैंने कहा, "So what do you want?" "Sir, थोड़ा patient stable कर लूं, फिर phone करता हूं." मैंने कहा, "Done." I asked my SR to go. My SR went. He says, "Sir, abhi to BP bada low hai, to baad mein dekhte hain." Half an hour later, that guy comes, calls me again. "Sir, I have pushed enough fluids. Now radial pulse is palpable, but DPPT is still not palpable." That's the term we use here for dorsalis pedis and posterior tibial. I said, "So what?" Kehta, "Sir, I want to get CT angio done. There's something wrong in this patient. मेरे को कुछ ठीक नहीं लग रहा." Now, my SR was at variance with my resident. So I said, "I'm coming in 5 minutes." So I left home, drove down to the hospital, and he was right. DPPT was not palpable, and I really appreciated his decision. We stabilized and took the patient for CT angio, and this is what we found. So that's what it takes to be a good resident. The limb that survived, this limb survived, the patient is walking on his own foot with sensations, is not because of me, is because of that resident who had an index of suspicion. मैं मानता हूं शायद वो 2 एनजीओ फालतू भी करवाए होंगे अपने 6 महीने की पोस्टिंग में. Doesn't matter. If he saved one limb of a young man, it's worth it. And the credit goes to him, not to me. He was the one who anticipated it. Now another patient, how do you inform this to your consultant? Right? This is how the patient came. Now, if I no history, nothing, oh, sir, ek bone gap aaya, sir, infected non-union ka. No condition of the bone, no joint functions, no neurovascular functions. Sir, Elizarov ke liye rakh le kal. This is not expected from an orthopedic resident in emergency. You have to examine patient as a whole. Examine patient as a whole. Another patient, "Sir, reconstruction ke liye kal rakhna hai, sir." Even the slab was not opened. The senior resident went, opened up the slab, and this was the condition. He had actually been operated by another institute, not an outside orthopedic surgeon. They opened up, they found that the collection inside was looking infected. They abandoned the procedure. So examine the patient as a whole, look at the patient's condition, open up the dressings and slabs, examine the patient in totality, document everything, do a thorough clinical examination. I still remember there was a photograph put up in our medical seminar room when I was a student. When I diagnosed a patient which others had failed to diagnose, the only difference was I applied a method of clinical examination which they had not done. So clinical examination can never be undermined. Investigations will not get you out of every damn thing that you see. So I'd like to acknowledge AO Trauma and my friends from OTA, my team Ortho from DMC, my teachers, Professor S.C. Ahuja and Professor J.L. Bassi, Mandeep Dhillon, being a mentor, a friend, and a guide, and Professor Hans Krether, who is my mentor for last so many years, my patients and my family. Special thanks to AO Trauma because my perspective as a teacher has totally changed after I became part of the AO family, more so after I did my tips for trainers, then advanced faculty program, and then chairman's program. Now I am actually a coach in AO trauma family. That totally changes your approach to teaching. You know, डरा के, धमका के, गुस्सा करके is not the way to teach and to go forward. So if I say that, that is why I put AO trauma on the top, because these guys, they prepared me for what I am today. Some of them polished me for what I am today, but AO trauma was the one who has shined me like a boot polish does to a boot. And without the support and the opportunity given by my patients and support of my family, this won't have been possible. Thank you.
Thank you, sir, for this wonderful, well, comprehensive and lucid presentation. And you have rightly said, behavior, communication, and dress code, change of mindset, and most importantly, a wonderful bonhoming with the paramedical staff is very important. And I would like to mention about this very pertinent video you have shared. This is also a problem in many institutes that residents often share very limited information. So you have rightly explained to them that why they need to share all the kinds of very comprehensive and all the kinds of all-inclusive information to the consultants. Thank you so much, sir. We have few questions from residents. Sir, you have mentioned that residents, they have to do ATLS courses, but we often see that residents doing MS courses, they are not trained in ATLS. So what would you advise them? All should get ATLS course done during their 3-year residency.
See, the point is, we are orthopedic surgeons, but majority of all of us, apart from few exceptions, we are trauma surgeons. And residents train in a medical college where trauma is an important part. You know, they are usually secondary or tertiary level trauma centers for their respective areas. So ATLS should be must. I would say if you, just a small thing for the residents, since you asked, I always tell all my residents, jo bhi kamate ho, uska 10% alag rakho and invest that into your profession. Buy a book, do a course, or do anything that will increase your professional proficiency. So Dr. Ram is here. So I'll request him that apart from the PG training that they have wonderfully done in cadaveric courses, I think we should take up either a formal ATLS course or we formulate something on the similar lines which is cost beneficial to the residents, because management of trauma in the emergency, especially if 2 or 3 long bones are injured or it's a polytrauma, is very important.
Yes.
I've seen a fight going on. Ki patient abhi karna, and the lactate is 2.5, 3.5. And I tell my residents, cool down, boss. This patient is not going to come out of the operation room if we go ahead like this. Resuscitate the patient first.
Yes. Sir, in your presentation, you have also advised residents how to tackle crowd and that apprehensive attendance of the patients. I believe that is very helpful. Since first year residents, after joining duty, they have to go to emergency and do emergency duties, and they are very apprehensive. So that advice would be very helpful. So any more advice you would like to give them to tide over their apprehension during initial days of residency, during management in emergency?
First, little controversial statement. First year should never be posted in the emergency department because he's too new to understand and work on orthopedics. And second, be confident, be properly dressed, be confident, because the patient doesn't know who you are. Don't try to show your incompetency to the patient. Never talk in front of your staff. Oh, ye to galat ho gaya mere se. You know, speak minimum, but your actions should be this. And try to be very confident with the patient. Keep the communication channel open with the patient, patient's family. They are not looking at what is being done. What is shown to is being done is more important in today's world. कि आपने ड्रिप लगा दी उसका मतलब नहीं है, आप उनको बताओ देखो हमने ड्रिप लगा दी है जी, अब बीपी ठीक हो जाएगा, 10 मिनट बाद यू कैन शो देखो बीपी थोड़ा सा ऊपर आ गया, हमने दूसरी भी ड्रिप लगा दी है. Then they start forming a bond with you. That is what is my experience is. And it's, if you ask, I think most of us would have had the same experience.
Right, sir. Sir, one resident has this question. He asked, what are the must-know orthopedic procedures for residents that can be life and limb saving that should be learned during their 3-year residency?
Life or limb saving procedures, so boss, first is the bleed control, compression bandage. We never rush into a ligation in the emergency room unless we can see the cut end of the artery lying in front of us. Right? So rest is joint reductions. I would say that you should have an emergency manual of orthopedics in your pocket. Try to read up as much as possible. That will give you an insight what all you will need to know when you are attending to the emergencies. देखिए ऐसा है, Watson Jones की line है, it is not my own. Fracture clavicle can also cause death with bleed. So unless you have read up and you know this can happen, the patient can be in shock with fracture clavicle and you will keep on thinking इसको chest injury है या इसको abdominal injury है.
Yes, sir.
So it's nothing like ये 5 चीजें पता होंगी तो छठी नहीं हो सकती. You need to know orthopedics in totality, and knowledge is the base. Knowledge के बिना आगे नहीं चल पाएंगे, as has already been said by previous 2 speakers.
Yes, sir. So, do you think that we are overly dependent on kind of artificial intelligence or social media like WhatsApp during emergency management? Can this artificial intelligence supersede clinical acumen? Since lots of communication are being done on WhatsApp, sending clinical pictures and X-rays. So what's your take on that, sir?
So, trauma centers are of 3 grades, 1, 2, and 3. Level 3 is the one, or it's level 1, I think, where all specialists are available inside.
Yeah.
They are available 24/7.
Yes.
Level 2 is where they are on call. So in India, we are level 2 trauma centers where everybody's on call except few of those that have come up. I suppose the AIMS New Delhi Trauma Center is level 1 with all consultants present inside. So in that condition, you cannot say we are over dependent on technology. Let me tell you a personal anecdote on a different line. One of my relatives was admitted in the cardiac ICU and had a problem, complication while being admitted there. और उन दिनों क्या होता था, ECG करी, मैं उस ECG को लेके अपने कुलीग के घर गया जो फैकल्टी मेंबर था, उसको दिखाई, उसने उसके पीछे ट्रीटमेंट लिखा. In those days there was no intervention. दवाई का हेर फेर होता था, थोड़ा सा ये बढ़ा दी, दूसरी ऐड कर दी, कुछ कर दिया. I went back, told the resident कि यार ये दवाई सर ने लिखी है, चेंज कर दो, या ये डोज बढ़ा दो, हेपरिन और बढ़ा दो, ये कर दो. And then I talked to that consultant कि सर अगर आपके घर फैक्स हो, यहाँ से फैक्स कर दें और कॉल कर दें, won't that make your life also easier? कि आप सर्दी में उठ के गेट तक आए, कहते हैं तेरा आइडिया तो बहुत बढ़िया, पर ECG फैक्स पे क्लियर जाएगी कि नहीं जाएगी? I'm talking about those days जब फैक्स इतनी क्लियर नहीं होती थी. So, and I have seen other places, I can name them also in other parts of the world, where the whole process is on software. The resident doesn't need to upload. He just calls up, informs the consultant there's a case. He can get into the hospital system from home. He sees the X-ray. He can even plan it using the software.
Yes.
इसमें external fixator लगाना है और यहाँ जगह पे pins होने चाहिए. या अगर प्लेट लगानी है तो इतनी लंबी लगानी है, वो conveys it back to the trauma team, and trauma team has to follow those instructions. So technology, whether we like it or we don't like it, social media, we like it or not like it, we are part of this society, and as such, we'll be part of the social media. Or I know some people who will switch off their cell phone and they say, some people think it's fashionable to be connected all the time. I feel it's fashionable not to be approachable anytime. They enter hospital and they switch off their cell phone. They say, this is for my family. When I go out of the hospital, I'll switch it on. I said, what if your family needs you? They know where to call me. They'll call my secretary. So that's the other side. If you're so feel it is toxic, you can take the other path, but then it's all, we are part of the society. We are social animals.
Right, sir. Sir, and the last question, since we have seen some rising incidents of violence in emergency, and often residents are the first point of contact. So, and during emergency duties also. So, would you like to give some advice or your insight into this? How to tackle this kind of incidents, or how to avoid this in brief?
First is empathy. Be nice to the family on the first go. I know residents are overworked and they are not so mature, and the family is already apprehensive. Today, recently, I was just checking up the medicos group, Med Twitter, and there's been an incident of violence in Chhattisgarh. You other people also must have seen. A resident is badly beaten up. मतलब उसको चपेड़े लगाई हैं 2-3 बंदों ने इकट्ठे होके. And my reply to that was, thank God, my son had finished his MBBS, had done his internship also, and finally I've been able to convince him not to pursue medicine further. So, because the reason I'm telling you, it's this resident one day, it could be my son another day, another place. Right? So there's no cookbook recipe how to tackle it. Some part of the changes are needed in the society. Some part of the changes are needed by us. We as senior doctors have failed in our duties. If our resident in the emergency department is manhandled, the fault is with us, not with the resident. क्योंकि अगर वो रेजिडेंट ठीक नहीं है तब भी आपका काम था उसको ठीक करना, और अगर वो ठीक है, nobody has any business to touch your resident. I always say, if it was your son or your daughter, तो आपका क्या रिएक्शन होगा अगर उसको कोई इमरजेंसी में जाके मैनहैंडल करे? Same should be your approach when your resident is manhandled.
Right, sir. Thank you so much, sir, for sharing your thoughts. We, on behalf of Jharkhand Orthopedic Association, express our thanks and gratitude to you for sparing your valuable time and be among us. Thank you so much.
Thank you.
So I believe we can move on to the next session. And for that, I welcome Dr. Manish Raj, sir, to start to moderate the next session.
Thank you, Harpal Singh Selhi, sir, and thank you, Dr. Saubhik. Our next speaker is Dr. Chadda, sir. He is a very known figure in orthopedic community at national and international level. He had done MD orthopedics from prestigious LTM Medical College and General Hospital, Sion, Mumbai in 1989, and then continued his passion for teaching in the Parent Institute as associate professor. Sir has vast experience of more than 33 years in spine surgery, and he had done multiple advanced fellowship in orthopedic and spine surgery in France, Germany, Switzerland, and USA. Sir is the pioneer of MICOS, minimally invasive cosmetic spine surgery in India, and developed different technique for surgeries in the spine field. Sir is a wonderful orator and regular keynote speaker at various national and international scientific platforms. Chadda, sir, is a pioneer in the field of robotic spine surgery in India and is a strong advocate for safe spine surgery. Chadda, sir, has previously served as a past president of Association of Spine Surgeons. He is also past president of Bombay Orthopedic Society and Bombay Spine Society, and is presently serving as vice president of Indian Orthopedic Association. Beside his academic achievement, he is a person with golden heart, very humble and down to earth. And he is going to today speak on development of communication skill, a must know for postgraduate students. Sir, it is our honor and privilege to have you here, sir. The stage is now yours, sir.
Thank you very much, Manish ji. At the outset, I would like to inform and appreciate the efforts of the Jharkhand Orthopedic Association, which has kept their flag flying high and is doing immense service to the Indian Orthopedic Association by having their second postgraduate course today on the online platform. You've had excellent inputs from all members of the JOA who have been here as moderators, and you've probably picked up an excellent faculty in the form of Dr. Aloo Agrawal, Dr. Chatterjee, Dr. Selhi. And I loved the way each one of them have actually, on Father's Day, shared a very role model or mentor-based information to each one of you seated and wishing to learn from them. They are not just role models, they are mentors, and you are their proteges. And they have tried their best to share in a crystallized form, not just information, but knowledge and pure wisdom. They have told you exactly what needs to be done so that you don't make the mistakes that our generation probably made. I'm here sharing with you something which at our time was not a part of the curriculum and is today still not an integral part of the official curriculum of orthopedic training in our country. These are social skills, soft skills, communication skills, which are a must know for each one of you today. I am most honored and privileged to be here as a part of this fantastic collection of speakers and faculty who have contributed in making a dent in the way that you think about orthopedics and medical training as a whole. What is success and how do we achieve it? Well, it's a combination of effective communication and teamwork. I'm here sharing with you how your communication skills can make you successful. We all have different ways of looking at success. Some of us feel that when we are successful, we shall be happy. But I think it's the other way around. Success does not beget happiness. Happiness begets success. And how can we be happy? We can be happy when our words and our actions actually translate our thoughts. And hence, your thoughts have to be first correct. Always think before you talk. What do I mean by think? Think, T-H-I-N-K. Whatever you say has to be true. It has to be helpful. It has to be inspiring. It has to be necessary. And it has to be kind. These are 5 words which are an integral part of communication. Every word you say to a patient, to a caregiver, to a family member is a part of your success. And it has to be true, helpful, inspiring, necessary, and kind. Success finally is when reality resembles our imagination. Success for your quality of care is when what you do to the patient is what he and you as a team have imagined. Effective communication is when a person wants a desired outcome by sharing key information or news. And teamwork, it's not a group of people who work together, but it's a group of people who trust each other. As so beautifully mentioned by the previous speakers. If my resident is doing something, he should speak my language. And my resident should be good enough to treat me. Tomorrow I have a problem. My resident should be the one who will be treating me and nobody else. That's a team. TEAM. Together, everyone achieves more. Yes, I started with information, knowledge, and wisdom. Information, we are getting so much of it. Dr. Selhi said, keep 10% of what you earn aside and use it to get books, attend conferences, attend meetings, something that will enhance your knowledge. Information and knowledge. But then with your experience and creativity, keep only what is important within, and that is wisdom. All the rest is garbage. It has to be thrown out. Success in orthopedics will come with effective communication and teamwork. The teamwork and communication will depend on what your purpose is. Your purpose is to truthfully heal the patient. Healing, treatment, diagnosis, these are all different words. And somewhere today, we are going wrong. We are going amiss. The previous moderator repeatedly asked, today we see doctors getting assaulted. How do we look at this situation? Sion Hospital is my alma mater. We faced it. Mumbai is the city I come from. We have faced it. My state has suffered 5 attacks in a week a couple of years back. Yet, the people who were supposed to protect us, unfortunately, have let us down. How do we handle these situations? Let's begin with a situation which is not unknown. I'm sure it happens to each one of you. If not today, it may have happened yesterday. It may happen to a few of you tomorrow. Unhappy relative of a patient who's had a post-operative adverse event barges into your clinic, which is packed with patients, and insists on seeing you there and then. How will you handle such a situation? Will you stop the present consultation and see him right there? Will you finish the present consultation and see him right there later? Will you politely have him seated in another room and see him after the consult? Or will you admonish him, get your support staff to make him sit outside? Well, today where we are, unlike what you may have done a few years back, the best way forward is politely have him seated in another room and see him after the present consult. Gives him some time to rethink, gives you a lot of time to rethink and plan and be proactive. It also gives us a lot to think about and to protect ourselves and others around us. What do you see in this picture? You see a caregiver right there staring into the eyes of a healthcare provider. The patient is out of focus. He is in the background. It's the caregiver who's admonishing us. Why is this happening? Because there's a mindset malfunction today. Patients see doctors as predators and themselves as praise. They look at us like this. They think we are surgeons who are only interested in cutting them up. And how do we look at patients or their family members? We look at them as predators and ourselves as praise. That means there is some mismatch, some misunderstanding. I think it's time to pause, think, reconsider. Why is our patient unhappy today? We stop, look within, and then come up with a solution. There is something amiss somewhere, which probably was not there a few decades back. Always in life, whether it is while training, while teaching, or while doing anything truthful, you have to start with why. As I mentioned, healing, treatment, and diagnosis are three different aspects of the same journey. But there is a huge dichotomy here. Healing is a purpose. Why are you doing something? To heal. How are you doing it? That's a process. That's the treatment steps. And what are you using to achieve this? A diagnosis. And that's the what. We have been always taught that we've come to this noble profession to give back, to give a helping hand, provide it. Healing on one side is based on faith, belief, trust. These cannot be measured. These have to be felt. Unfortunately, God and doctor, we alike adore. Once danger, we are in danger, not before. The danger over, both are alike requited. God is forgotten and the doctor is slighted. So we are put in that demigod position. But once things are slightly better, Bhagwan bhi bhul jata hai, doctor bhi bhul jate hain. Why is that so? Because treatment and healing on one side versus diagnosis on the other don't go hand in hand. Treatment is based on truthfulness, transparency, and empathy, where we connect to the patient and believe as ourselves as a part of the patient. But diagnosis, it's exactly the opposite. There is skepticism, doubt, suspicion. So on one side, we're talking of faith. On the other side, we talk of suspicion. That is where our particular profession and our science suffers. What else have we done? Well, we have a rather poor image nowadays as doctors. It's a combination of media, the way they look at us, and the few black sheep, which may be there in every profession, but are highlighted in ours. How do we then go ahead? Unfortunately, we have expensive healthcare. Expensive is relative because it's out-of-pocket expenditure in majority of our people in our country. There is inadequate security in small centers. There's an impatience and mob mentality today. Today, everybody wants right now. As I say, there is this instant gratification attitude, the Amazon Prime gratitude, which has crept in. They want treatment now and right now. We have given unrealistic expectations to our patients. And often we have improperly communicated or consented for procedures. What's the type of violence we see? Telephonic threats, intimidation, verbal abuse, physical non-injurious assault, physical assault, simple and grievous, at times murder, vandalism, and arson. We've seen all of this. How do we get affected as doctors? We get depressed. We lose our sleep. We develop post-traumatic stress. There's fear and anxiety, absenteeism from work. And yes, as you've seen recently, a few of us commit suicide because we can't take it anymore. How can we prevent this? Well, the government needs to give us a safe environment. They need to do two small things. They have to avoid media sensationalism of deaths. And second, some legal steps where any complaint made by a patient should be cancelled ab initio if proof of violence by patient or kin. What do I mean by this? If you've been violently exposed to a patient by the patient or the relatives, they should not be allowed to complain. If these two things are put in place, we would be alive to give a good solution. Otherwise, we are going to suffer. I am very unhappy when I read a few statements. President of India recently has been quoted to say, as doctors, your services must be available both to those who can afford your fees and also to those who are less fortunate and cannot. It is for society to profit from medical science. It is not from medical science to profiteer from society. It's just that we are being wrongly interpreted. I'm sure all of us accept and believe what the Honorable President has said. But why should he say that? Why should the police chief in the state of Maharashtra make a statement like, do not treat your patients like a commodity? Police commissioner issued a stern warning to doctors in his weekly social media address on Sunday, saying he would act against them if they prescribed unnecessary tests for the sake of commission. How do these people come to know of this? I think we have to look within rather than look without. Somewhere we are going wrong. How do these people believe that we are making such unnecessary tests for the sake of commission? Yes, the Lancet has shamed India for complete failure of the police, judiciary, and politicians, which has led to raising violence on doctors in the country, 70% putting off people from joining medicine. And it is so true. How many fathers among us today have actually been unhappy that their children have taken up medicine? A lot of us have encouraged them to look elsewhere. This will lead to further brain drain and shortages and further increases in quacks treating Indian patients, leading to further substandard results, further violence, and a vicious cycle. On the other side, we see that we still belong to the 10 most respected professions in the world, and we top it. We are far above the lawyer, engineer, head teacher, police officer, nurse, accountant, local government manager, management consultant, and secondary school teacher. Mind you, many of the people who commented don't even come in this list of the first 10. How can we prevent the violence? We have to take a few steps. We should not overreach a prognosis. Very realistic in the way we look at our patients. Take valid informed consent. Have a detailed written documentation. Whatever you communicate has to be documented, written down. And whatever you have documented has to be communicated. So it's what you say has to be on paper, and what's on paper has to have been said in a language that the patient and family has understood. This communication has to be empathetic. You should always be alert for potential violence. It should be there at the back of your mind. Well, not very far back, 1st of March this year, orthopedic surgeons have a high prevalence of burnout, depression, and suicide. Review of factors which contribute or reduce further harm. It's Journal of American Academy of Orthopedic Surgeons, something which is revered by many of us. Hence, I always say, sometimes it's better to just remain silent and smile. You know the word silent, S-I-L-E-N-T, if you rearrange the words and put the letters differently, S-I-L-E-N-T and L-I-S-T-E-N, listen, have the same set of letters in the word. Yes, we should listen silently and smile. But then adverse events can happen. When they do, don't lose hope. Remain calm. Have a photographer or a video recorder. Copy all your medical records. Inform the lawyer. Inform the police. Maintain a recording of call to the police. Whenever there is such an event, identify that troublemaker or leader of the mob. Take written signed statements of all witnesses besides the mob. Lodge an FIR with the police specifically under the relevant act to protect medical personnel. Never settle for hush money. This hush money to settle or hush up matters is taken as an admission of guilt. Always remember, you should be charming yet correct. Keep smiling. This too shall pass. I always respect something which Dr. John Guliana mentioned, and as a part of his advice in the essentials of running your medical practice. He said, always do the right thing. Meticulously document any conflict. Never lose your temper. Stay out of danger. Never be distressed by insistent patients. Investigate the patient's mental state. Never shirk any difficult patient. Always do what is right, not what is easy. Be kind, be humble. Always there should be integrity in doing the right thing, even when no one is watching. You have to practice pristine honesty and not majority honesty. Always remember, things are not very easy. Stone is broken by the last stroke of the hammer. That doesn't mean that the first stroke is useless. Success is a result of continuous, persistent efforts. Keep trying. Keep trying. You may fail, but keep trying. Ever tried, ever failed, no matter. Try again, fail better. Have essential communication skills. Open and frank with the patient. It's a creative art which has to be developed throughout the medical career. We should be learners and seekers forever. We have to be students. It's a lifelong pursuit. Remember, all of us do not have equal talent, but all of us have the same time and equal opportunity to develop our talents. Always remember, whenever you meet a patient or a relative or a caregiver, remember, everyone you meet is fighting a battle you know nothing about. Reality should look like your imagination, only then is it success. But it's not a straight line. There are a lot of challenges, failures, obstacles, finally, before you achieve success. Yes, we have to practice advice and counseling. 2/3 of our problems can be sorted out without medicines. Advice and counseling are two most frequent modalities of treatment. Mental health consultations are important in today's world. People are carrying a huge monkey on their back when they come to us. We have to help them offload that monkey. Remember this. Depression, anxiety are very, very common problems. And today, the mental health needs to be treated of the patient and of our doctor colleagues and caregivers. Nothing in the world can bother you as much as your own mind, I tell you. In fact, others seems to be bothering you. It's not others, it's your own mind. Remember, as cold water and warm iron take the wrinkles of clothes, a cool mind and a warm heart takes out the worries of life. Always balance between the heart and the head. The heart decides the why, the head decides the how, and it's the hands which decide what needs to be done. There are 9 effective components of communication. Listen to the patients, respect their views, have open communication about all treatment preferences, discuss all management options and non-surgical options, allow patients to ask as many questions as they want, ensure that they've understood, be aware of their language, accept the cultural influences, and compensate communication issues. You are neither above nor below the patient. You're always besides the patient, hand-holding them. Best form of service is to uplift someone's state of mind. Let them go from a mindset of scarcity to a mindset of abundance. Move them from a fixed to a growth mindset. That's the way that they will improve. Importance of non-verbal and verbal communication are so important. Remember, there are 3 ways that you really can communicate. which are verbal and non-verbal. But if you look at it, it is verbal, vocal, and visual. Verbal are the words you use. Vocal is the tone of your communication, the volume, the way you speak, the way you pause, and visual is your body language. Yes, many years back, there was a quotient given to each. It was given by a gentleman called Mehrabian. And he said, verbal is just 7%, while visual is 55%. Vocal is the compensation in between, which is 38. Hence, remember that it's 7% words, 38% how you say them, and 55% what your body language communicates. Hence, we have to go with this 7, 38, 55 rule of Mehrabian. Always build a shared understanding. Have an open, attentive posture. There should be an eye-to-eye contact. Actively listen to them. Use cues such as nodding during the non-verbal communication. Encourage the patient to tell his whole story. Let them ask open-ended questions. Remember, the mind is a beautiful servant, but a very dangerous master. The mind should be our servant, not our master. If you believe that common sense is easily available, no, it's not. It's not a gift. In fact, it's a punishment because you have to deal with everyone who does not have it. Tough times never last. Tough people like you do. If you're going through hell, just keep going optimistically. This too shall pass. Teamwork divides the task, multiplies the success. You must remember that if you want to walk fast, walk alone. But if you want to walk far, walk together. We are all surgeons, and we carry within us a small cemetery where from time to time we pray, a place of bitterness and regret, where we look for explanations for our failures. Yes, it's time that we introspect. We learn, unlearn, and relearn. We go from the conventional to the contemporary. We have to change our focus all the time, from within to without and back within. We have to look and relook at what we do and how we do it, why we do it. Finally, what the mind conceives, the heart believes, the body can achieve. Beware of your thoughts. It all begins in the thought. They will soon become words. Beware of your words. They will soon become actions. Beware of your actions. They will become habits. And your habits will become your character. And finally, your character will decide your destiny. So your thoughts decide your destiny. Think before you talk. Is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind? What the mind conceives, the heart believes, the body achieves. What the head conceives, the heart believes, the hand achieves. We may all be confident, but there's a very thin line between confidence and arrogance. It's called humility. Confidence smiles, arrogance smirks. Always speak in such a way that others love to listen to you. Listen in such a way that others love to speak to you. We've all become doctors. Our prime purpose in this life is to help others. If you can't help them, at least don't hurt them. Primum non nocere is what we learned, and Dalai Lama has so well interpreted it. The final message: don't just look, but see. Don't just hear, but listen. Don't just touch, but feel. Don't show pity, show compassion. Don't feel sympathy, but empathy. Truth and transparency build trust. Compassion goes beyond sympathy and empathy. Compassion is what makes you altruistic. Whatever you do will be good for the larger part of whatever we are doing in life. We are not born, we evolve. The reality is not seen by the world, but we have chosen to be doctors and we are obliged to live so because we want it to be so. Build the trust. If one line you have to take home for the rest of your lives, remember, don't practice for income, but for outcome. Move from knowledge to wisdom, as I said. Move from selfishness to selflessness to altruism. Whatever you do is for the larger good. We are but instruments of a much higher force. Move from information to reformation to transformation. We've done our duty for too long. We have to now find our calling, that purpose, that passion. Move from Yoga Jog to Sanjog, connect with the patients. Don't just do Kriya. It's time to start doing some karma. Only then will you move from treatment to healing. The mission of your life should be to leave this world a better place than what you had inherited it to be. I say this prayer every time, every day, especially before I operate on a patient, because I know that as a surgeon, I can only alter the anatomy and hope that it converts into a change in physiology. I say, God grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. Bhagavad Gita also said the same. Thy concern is with the action done, never with the results. Let not the fruit be the purpose of your actions. Therefore, you won't be attached to not doing your duty. Find that balance and you will then lead a happy life. I've always said, happiness begets success. Success does not beget happiness. Follow these 10 two-letter words and you will be happy and successful. The 10 words are, if it is to be, it is up to me. You have to change. Don't expect the world to change. We don't live in a perfect world. All we can achieve is excellence, not perfection. Thank you all for a very patient hearing. God bless you and practice safe surgery. Thank you so much.
Thank you, Ram Chadda sir, for such a wonderful presentation. Your golden words, success in orthopedics, come from communication and teamwork is something which we all have to remember always. There are some questions from the participants. One of the participants had asked, do communication-based skill course should be started at the MBBS level?
My humble request to him is to make this question universally so loud that it should be a part of a curriculum in our country. Because today we seem to be lacking that. And we as the parent organization are pressing for it, but it would only happen where we are actually represented not just by a group of nominated or elected members, but by the voice coming from our younger members. And if this gentleman feels so, and if he represents the majority of the younger youth which is in front of us wanting to sort of follow it, I'm sure somewhere, whether it's the National Medical Council or the Medical Council of India, they would look at these soft skills being a part of medical training right from the beginning. It is very, very important.
Yes, sir. So soft skill development are now part of the curriculum as mentioned by NMC. Another question is by another participant. He want to know the communication skill in medical education is nowadays synchronous with English oral skill. Actually, many our students are from different background. So many students are very confident in theoretical, but not expressive, especially in English oral skill. Sir, what is your take on this?
Sir, if you were attentive, and I go back to what I said, sir, I spoke about the Mehrabian communication percentile, where I spoke about verbal, vocal, and visual. And I said 7% verbal. So the language is only 7%. 38% vocal. आप किस तरह बोलते हैं? शब्द जरूरी नहीं, लेकिन किस तरह उस शब्द को आप इस्तेमाल करते हैं. And 55% is your body language. So even if you don't know English, you're only compensating 7, you're losing 7%. You still have the other 93% with you. Humility, humbleness is not language, it's in silence. So that's all. I mean, that 93% every one of us has. We don't need to speak in English. आप किसी भी ज़बान में बोलिए, क्या फर्क पड़ता है?
Yes, sir. Sir, personally, I want to ask, do you want to suggest the audience something, how to communicate the bad news to the patients? Especially
Sir,
bad news.
Sir, I'll be very frank with you. There is no news which is bad news. It's something which is relative. Okay? हर चीज सापेक्ष में देखी जाती है. We always have to be truthful from day one. From the moment that the patient arrives, we have to give them realistic expectations and not non-realistic. If you've given them realistic expectations and have held them through the journey, they believe that you are as much a part of their family. And hence, what is bad news to them is bad news to you as well, and they accept it more easily. However, if you have been contrary to that and you've been actually walking them on a different sort of an image that things are perfectly fine and everything is going well, and then suddenly something goes amiss, no, then we went wrong in our communications. So if we are sharing the unexpected, please remember always you have had the opportunity to prepare them for the same. When you counsel them the first time, you have to tell them realistically everything that can go wrong. And if you've done that, yes, with a heavy heart, but you have to be truthful and tell them. So it's always best to frankly tell them the truth and do it the way you would to your own family member. So you have to be compassionate and empathetic. You have to be a part of the suffering team rather than the one who's just sharing the news. So I think it's difficult, but it is doable, provided you've connected with them, there is a bond with them. And that comes with time, sir.
Okay, sir. Thank you, sir. We are already running short of time. So I'd like to invite the Secretary of Jharkhand Orthopedic Association, Dr. Nirmal Kumar, for his vote of thanks.
Thank you, Dr. Manish. And let me thank all the faculties for inviting for accepting our invitation and for being on this show program. All the topics and all the speakers were excellent in their presentations. And I hope this must have benefited our targeted audience, not only them, but also even the practicing orthopedic surgeons, especially the last talk that was all about communication skill. And I would again thank from core of my heart everybody involved in making this program successful. The faculties, our PG teaching team from Jharkhand Orthopedic Association, and last but not the least, Ortho TV, without whom this would not have been possible. So at the same time, I would request and expect our faculties in today's program to be with us in future programs also, and also to give us their feedbacks regarding how we can improve it further, so that we can be useful in different settings, and what else we can do to benefit and to take our president's and Indian Orthopedic Association theme of taking academics to a different level, and also to contribute in a positive manner for overall growth and development of orthopedic specialty in India. So thank you again. Thank you so much for spending all your valuable time, the people who participated. And we hope to see each one of you again very soon. Thank you.
Thank you very much, everybody.
Nirmal, thank you, sir. Thank you, Ram Chadda, sir. Thank you, Chatterjee, sir. Bye, sir.
Thank you, sir.
Thank you, sir.